Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Please go ahead.
Thank you. Next slide, please. Good afternoon, everyone. My name is Lisa Sullivan, and welcome to the live Q&A session associated with the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management Training Series. The live Q&A sessions are dedicated entirely to interacting with participants, sharing comments, and taking questions, and are intended to supplement the online training topics and provide nursing home personnel with an opportunity to ask questions of the CMS and CDC as they navigate through the pandemic. Thank you for taking the time to be with us here today, and a special thanks goes out to our CDC colleagues for partnering with us on this important training series. The slides from today will be available on the QIO program website, and the recording from today's event will also be posted there within a week, so be on the lookout. Next slide, please. With all the changes to the series and training offerings, we're going to provide a brief overview of how to locate some of the important resources located within the QIO program website. This slide shows a snapshot of the tabs on the QIO program landing page, which is found at qioprogram.org and contain many useful reference materials. We're going to focus on the Nursing Home Training tab, which is highlighted on the left with the red arrow. So you would go to the website and you would click on Nursing Home Trainings. Next slide, please. And it's through this Nursing Home Trainings tab that the user can find information about the on-demand trainings and schedule associated with them, the Training Fundamentals Self-Assessment Tool, the Toolkit on State Actions to Mitigate COVID-19, frequently asked questions, and some additional resources as well. We'll briefly discuss what is contained in this section of the QIO program website so that our audience has the information about accessing the valuable resources included within the site. We will focus this portion of our discussion on the first option in the drop-down menu, which is the On-Demand Trainings link. It's circled here for your quick reference. Next slide, please. The On-Demand Trainings link is where one can find everything associated with our training series. The first blue heading is linked to the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management page, which contains the critical topics of recorded training sessions along with registration links for the live Q&A sessions, such as this one, and slides and reference documentation from each training. The Comprehensive National Nursing Training Home Series link, the next blue heading on the list, encompasses our intensive fast-track instruction on infection prevention and control, and this is tailored to nursing homes located in areas with increasing COVID-19 infection rates. This is a great first step for nursing homes in newly identified hotspot areas to obtain training in a quick and inclusive fashion. Next slide, please. The On-Demand Trainings link is also where one can find the toolkit on state actions to mitigate COVID-19 prevalence in nursing homes, in addition to the FAQs documents that answer a variety of questions previously received on some of our trainings. Please be sure to look at those FAQs as they contain guidance that will help with questions ranging from NHSN questions to COVID-19 testing. Next slide, please. Now, if you're not sure where to start in your training regimen, use our interactive Training Fundamentals Self-Assessment Tool to determine where to begin. This slide contains a snapshot of the tool to utilize. This will help you determine the training best suited for your facility. At the top left corner, after the blue circle, starts a list of questions designed to help you and your team strategize about where to commence your training. It was designed to help teams get started on their journey. Next slide, please. It is now my pleasure to introduce some of the featured colleagues on the call today to assist us with answering questions you may have. Today, we're fortunate to have the following CDC colleagues joining us: Dr. Namali Stone and Dr. Kara Jacobs-Slifka, our fellow CMS SMEs and COREs, Angel Davis, Marianne Butcher, and myself. Next slide, please. We are also joined today by our previous speaker, Jill Holt from Mountain Pacific Quality Health, who presented on the August 27th session, Cleaning Environmental Services and Shared Equipment, and also from the September 3rd session on Telehealth and Nursing Homes, Dr. Christine LaRocca and Nell Griffin from Telligen. We also have Dr. Raj Mahajan joining us on the call. Dr. Raj is President and CEO of Chicago International Medicine Practice and Research and leads its affiliated group of companies. Dr. Mahajan is the Clinical Associate Professor of Medicine at the University of Illinois at Chicago and is conducting telehealth visits with nursing homes. We thought it would be helpful to have someone with experience doing telehealth visits in the field on the phone to answer questions if any should arise. Next slide, please. At this time, we're going to turn this over to Dr. Namali Stone. She has some questions from a national call that I believe she wants to go over with everybody. So in the meantime, let me just remind everybody, if you have any questions, especially geared towards cleaning the environment or telehealth in nursing homes, please go to the bottom of your screen. There is a button called Q&A. Please type in there any questions you have, and we'll start the Q&A session once Dr. Stone is finished. So Dr. Stone, let me turn it over to you.
Thanks so much, Lisa, and thanks to all of you for joining us this afternoon or morning, I guess, depending on where you are. We have received questions from providers and partners over the course of this week, and I just thought I would start with a couple of clarifying statements, and then if there's additional questions that come up during the course of the Q&A, we can address them. But the first thing I want to talk about is when do you initiate an outbreak investigation? From our perspective, if there is a new staff case of COVID detected, or if a resident is diagnosed with COVID that is thought to be nursing home onset, and I'll clarify what that means in a moment, then there should be an evaluation of the exposures and initiation of an outbreak investigation, which includes expanded testing of staff and residents. A nursing home onset COVID infection among residents is defined as an infection where the onset is outside of the 14-day observation window of a new admission or readmission. So we talk all the time, right, about having an observation unit and placing new admissions or readmissions into that unit, caring for those residents in full precautions as if they may have COVID, because we know that there's a 14-day incubation window where somebody may be infected with the virus, but they haven't yet manifest any signs or symptoms. So if you admit somebody and within that first 2-week period, they develop and are diagnosed with COVID, that may not be a nursing home onset case. You still need to evaluate the practices and make sure that people were handling their PPE and doing all the right things, right, so that there wasn't any transmission. But that resident case could have been due to an exposure prior to admission. This is also the case if you know somebody has COVID and they're coming to you with that diagnosis, right? So that doesn't count as what we consider a nursing home onset case. But once a resident has been in the center for beyond 14 days, or if it's a long stay resident who's just been there for months or years and hasn't gone anywhere, those are the residents in which we would be concerned of a nursing home onset case and would prompt the initiation of an outbreak investigation, including the expanded testing of staff and residents. I just wanted to talk about that because we have been getting a lot of questions around that issue. And I think we'll stop there, and Lisa, if there's time or other questions come up around this area, we'll try to address them. Thank you.
Okay, thank you, Dr. Stone. All right, we'll go ahead and proceed with the Q&A session, and let me tee up the first question. And Kara, I think this one is going to be for you. If a resident is COVID negative and has never been positive, what is the recommended PPE to be used during care?
Hey everyone, this is Kara. I just want to confirm you can hear me okay.
Yes, we can.
Oh, perfect. Okay, thank you. I just switched to a different headset, so wanted to double check. But yes, thank you. So if a resident is COVID negative, or at least they've never been positive, you don't think or know that they have COVID, regardless, you all should be universally using your face mask or cloth face covering. So even for residents who are not known to have COVID, you should always be using that to begin with. Second thing is that for some of you, and there's more information in our overall IPC guidance for healthcare settings, but if you're in an area where there's a lot of COVID activity, if you are in a place where what we describe in the guidance is moderate to substantial transmission in your community, your staff should also be wearing eye protection, and that means goggles or a face shield. And that would be for all residents, whether they are negative, you don't know, positive. In addition to that, you definitely always want to still follow standard precautions. So if you are concerned for potential exposure to blood, body fluids, infectious material, you still want to think about that and use PPE accordingly. So I wanted to make sure I mentioned that first. But then if otherwise, or in addition to that, for someone who has never been COVID positive, they're COVID negative as far as you know, and you're not currently suspecting them of having COVID, you don't, unless you have concerns, you would not necessarily need to use any additional PPE. But if they are in observation, if you are in an outbreak setting and they're on a unit where you're doing that investigation and doing additional testing, those are situations where even if you don't know they have COVID, you would actually follow that guidance to wear all the recommended COVID PPE. Thanks.
Thank you so much, Dr. Jacobs-Slifka. The next question is for Dr. Stone. If an employee has been COVID-19 previously and 3 months has passed, do those employees need to start with weekly testing again? If not, when would you recommend?
Thanks. Yeah, so if a staff member has recovered from COVID and is now beyond that 3-month window where COVID testing is not recommended, then yes, that staff person would now be eligible for the regular staff screening. And the interval, like weekly or monthly or twice a week, is based on the county where your center is and the percent positivity of that county. Thanks.
Thanks, Dr. Stone. Next question is going to be for Dr. Jacobs-Slifka, and that is, in order to save PPE supplies, can staff sanitize the plastic face shield after use with wipes and then return that face shield back into the cabinet storing PPE supplies?
So this is Kara, and yes, face shields and goggles, these can be cleaned and disinfected and reused. I think the important thing is to make sure that in the process of doing that, you are performing hand hygiene and that you are following the instructions, making sure that you are adhering to the contact time that's recommended for that product that you're using, and that it is cleaned and disinfected before you are putting it in any kind of storage location, just so that anyone who is then going in to grab that item knows that it has been cleaned before they're now going to use it. But these are items that can be cleaned and disinfected and reused, and that also how you do this, or the degree to which you extend use or reuse of these items, is also going to be influenced by where you are at in terms of the PPE supply that you have. Thanks.
All right, thank you so much. The next question. If anyone tested positive once after being cleared and tested positive again, and weeks later tested positive again, is that person still considered to be contagious?
Yeah, hi, this is Namali. I'll try to address that. You know, we're still learning about the role of immunity following COVID-19 infection. And, you know, as our experience grows, we're going to update our approach to testing and precautions as we can. But right now, if someone who has recovered from COVID infection is now beyond that 3-month window where COVID testing is not recommended, then our guidance is that that person with a new positive result be placed in precautions, or if it's a staff person, you know, furloughed from work and managed as if they could be a potentially infectious case of COVID-19. And that includes assessing the circumstance of that positive test, looking for potential exposures, and consideration for initiating an outbreak investigation with expanded testing. And of note, I think it's important for us to also be aware that this approach, this recommendation for placing an individual in precautions and initiating an outbreak investigation for a positive COVID test in someone previously recovered, this is also the case if that person develops new signs and symptoms consistent with COVID-19 infection without any alternative explanation for those signs and symptoms, even if that positive test is occurring within that, you know, post-recovery 3-month window. Thanks for the question. Thanks, Angel. Bye.
Thanks, Dr. Stone. This next one, I'll go ahead and tee up. This is going to be for Jill Holt. And this question is from Victoria Bartlett, and her question is, how are other communities with carpets handling the cleaning? And she's looking to find out a little bit more about vacuuming. Are you vacuuming? Our SNF's healthcare center is COVID-free, and our policy states we cannot vacuum. So our infection prevention nurse is concerned with allowing vacuuming. Let me just add a little more background that we understand that COVID is airborne. We don't want to allow the particles to aerosolize, but we also don't want, we also want to make sure to keep the environment clean for the residents. Jill, you're still on mute, I think.
Are you able to hear me now?
Yes, go ahead.
If you are speaking, we don't hear you now.
And it looks like Jill's line has disconnected.
Okay. So this is Angel. I will go ahead and pose the next question to Dr. Jacobs-Liska, and hopefully we can get Jill back on the line. Is the CDC, CMS suggesting that face shields be used by staff in nursing homes with no COVID cases?
So the answer to this is possibly, or yes, in some settings. So CDC did come out and make a recommendation at least a few weeks back now, but made a recommendation in all healthcare settings, so including nursing homes, that if your nursing home or other healthcare setting is in a community or an area where you're having at least moderate to substantial transmission. So you've got a decent amount of COVID activity going on in your area, then staff should be universally wearing face protection or eye protection. And that could be face shields, but it also could be goggles that cover the front and sides of your face. Those are both acceptable options. And this is, of course, in addition to universal source control wearing that face mask. Thanks.
Thanks, Kara. I think we're still waiting for Jill. Jill, are you back online to answer that question about vacuuming?
Are you able to hear me?
Yes.
You are able to hear me?
Yes, we can hear you.
Yes, I can hear you.
Okay. So with regards to vacuuming, it is still permissible to vacuum. However, it is recommended that you utilize a special vacuum filter.
Okay, thanks so much, Jill. And did you have any additional follow-up for that?
No.
Sorry,
Thank
no,
you.
Lisa, that was, I'm sorry, that was Angel about to jump in with the next question.
Okay. Go ahead.
All right. So the next question is for Dr. Stone. So regarding the August 26 CMS guideline on testing, it states that all staff and residents who have negative COVID results will be tested every 3 to 7 days with a goal of at least 14 days of 0 positive cases. Does that mean that after 14 days of no case, will we only swab the staff and not the residents unless the residents become symptomatic?
Yeah, thanks, Angel. I think this is a really important question, and I think there may be others who are also submitting questions along the same lines. So let's sort of talk through the testing strategies. That guidance to continue doing regular testing on a 3 to 7 day interval for anybody with a negative COVID result is in the context of an outbreak investigation. So you start with a known case in a staff person, or as we were talking about, a nursing home onset case in a resident, okay? And then this is about the expanded testing I was alluding to. So all the staff and residents would be tested at the time that you detect a new COVID case in the center. And the reason for that, and broad testing has to do with the fact that we know, we have learned from many facilities' experiences, that when a new COVID case is recognized in a center, there is a very high risk that other individuals have become infected and may be clinically asymptomatic, but incubating and potentially even shedding virus that could be transmitted to others. So we want to find those asymptomatic infected people as quickly as possible. And then we can implement precautions and place residents as appropriate in a designated COVID care area and sort of do our cohorting strategy as quickly as possible. And because that initial exposure can extend for up to 14 days, right? That is the window of time following somebody becoming exposed to a case of COVID that you could be incubating the virus. At anywhere in that 14-day window, you could start to develop symptoms, start to shed virus. There could be people who become infected but asymptomatic the whole time. So if you're not looking for those cases, you can miss them. And that can be a reason a center has trouble containing their outbreak. So if you are testing all of the people who were negative on a regular interval, and really in the first week, doing it more often is going to help find people faster who may be infected. So every 3 days, every 4 days. I know that it all depends on testing supplies and capacity, but ideal case, we want you to be testing regularly to find those individuals who may have been infected as quickly as possible. And so you're doing this repeat testing until you can go 14 days without finding any new incident positives, any new cases that, and the reason it's the 14 days you want to go that long is it has to do with the incubation period of the virus, okay? So if I can get 14 days out and nobody else is converting, I feel pretty optimistic that I am not going to see more cases that could be due to that initial exposure. We often, in a lot of health departments, will recommend very close clinical monitoring like you're already doing for all the residents and all your staff as they're coming in, clinical monitoring, signs and symptoms, temperature checks, etc. And some of you may want to do that even a little more frequently than just once a day or just once a shift, because we'd like to go, another 2 weeks without having anybody else develop symptoms, without anybody else looking like they need to get tested. But and then we kind of get into, we go 4 weeks without any new cases. A lot of the health departments would kind of consider that, cluster that outbreak, closed. So you contained it and that's done. Once, you're done with an outbreak response and you're done with that more frequent testing of residents and staff, then you do convert, I guess, to your screening of staff that is outlined by the CMS, requirements based on, the county positivity rates and that tells you how often you're going to continue to screen staff once you're out of that outbreak testing. We do not recommend testing asymptomatic residents outside of an outbreak investigation. And so if you're not in the midst of an outbreak, then you are doing the screening of staff on an either weekly or biweekly or monthly interval based on, the county COVID experience. Okay, thanks.
Thank you, Dr. Stone. Our next question is for Christine, and it is a question from Julie Castley. Looking towards telehealth, after the official pandemic and emergency order, can you direct us to the requirements from a HIPAA security perspective so we can ensure any continuing telehealth systems are compliant? Christine, if you're speaking, we cannot hear you.
I'm so sorry. I think I was triply muted. Forgive me. I wanted to thank you Lisa, for this question, and thank you, Julie, for asking it. I'm going to lead, and then I'm going to turn it over to Dr. Mahajan. But it's an excellent question. As you know, the CMS 1135 waiver is temporary. However, we have heard directly from Administrator Verma that, she said the telemedicine genie is out of the bottle. And to that extent, there is CMS issued a proposed rule to expand telehealth benefits beyond the COVID-19 public health emergency. They issued that on August 3rd. In the training, 2 links are provided with additional information about that proposed rule. And if you'd like to comment on it, the comments are due by October 5th. Having said that, we also suggest that, there are allowable platforms right now under the temporary waiver, but it is a good best practice to start establishing and or strengthening your telehealth infrastructure and workflow. Right now we can use consumer-based, patient-friendly technology such as FaceTime, but it's a good idea to consider identifying and adopting a more traditional telehealth platform that has healthcare-specific features and security. That will not only add to the quality of your virtual visits, but likely the sustainability of your program. And with that, Dr. Mahajan, would you like to take a stab at this question?
Thank you, Christine. The only thing I need to add is the way things stand now are a lot of waivers around the public health emergency. And pre-emergency, there were several products that are evolved telehealth solutions for the settings that it was approved for. So there are the Hepa standards that are being followed, and most of them make that claim of being Hepa compliant. But the only addition I have is as this becomes a common theme after the emergency is over and current decision for CMS to continue, however modified way of allowing this in perpetuity, the HIPAA guidelines, regulations are going to evolve, and so I would say if people are vetting of certified products, most of them have those claims on their promotional material. But including myself, we here, at least in the nursing home setting, are using publicly available solutions to do that, and a lot of our work revolves around just addressing the technology piece of it. And the workflow. But as far as the security is concerned, a lot will evolve in the next several months as the emergency is over and telehealth becomes a regular part of caregiving here. Thank you.
Thank you both so much. So our next question, I'm going to pose it to Jill, but certainly if there are others on the panel that want to chime in, please feel free to do so. So the question is around cleaning PPE and storing in a cabinet for reuse by the same person or someone else. Is this best practice with sharing cleaned or disinfected shields or masks?
Thank you for that question. I believe that was addressed or touched upon in an earlier response. And, it depends on the place that PPE is being stored, and then also the sanitation process and clean hands in providing the cleaning and sanitation to the PPE. I think there might be others who have thoughts about that as well.
All right, thank you, Jill. And that person just kind of wanted to clarify some of the previous questions. Would anyone like to add anything? If not, we can move on. Okay, not hearing anything. Thank you so much, Jill.
You're welcome. Thank you.
All right, thanks so much. Let's move on to our next question, and this one is for Namali. Should we admit a resident who had a negative test or have had no testing and then test them on admission or shortly thereafter?
Yeah, great question. I do think that a lot of centers, especially as more testing capability becomes available, are sort of trying to determine how to best use the test. I'm going to give you my opinion, which is that I do not think that requiring admission, testing prior to admission, or even, doing testing yourself at the time a resident is initially admitted tells you the full story about their risk of COVID. And so we talked about a little bit earlier, there's this 14-day window of time from the moment somebody's exposed to when they can start to manifest signs and symptoms or start shedding virus that could be spread. And so if I, ask the hospital to do a test before I accept a resident, or if I deploy a test as a resident hits the door, I may know, if they're positive and could then, move them from my quarantine unit to my COVID unit. But the negative test does not, completely reassure me that they don't have COVID. And that's why we have consistently recommended people stay in quarantine the full 14 days, even, if they have a negative test at the time of admission. And then, at the end of that quarantine, if people choose to do a test, it just adds reassurance. It's not critical to do it, but testing in the window of time in between, it just doesn't tell you for certainty that that the person isn't incubating and harboring COVID infection. So along those lines, I think sometimes people get confused about testing, like the test-based strategy that we used to use earlier in the response, to demonstrate that somebody has recovered from COVID. And that was the requirement that after, their symptoms have to have resolved, and you can do, if you get 2 consecutive negative tests within, separate by at least 24 hours, then you can remove that person from furlough or from transmission-based precautions. That is it's part of recovery. That's when that test-based strategy was being recommended. And now we don't recommend it, right? Because we realize that there's a lot of ongoing detection of virus by these really sensitive PCR tests, and that virus is more likely to be fragments of DNA or RNA and not transmissible a virus, which is why we say don't retest people in that 3-month window following their recovery. That strategy does not work for removing somebody out of observation faster. It doesn't get you sprung from quarantine faster than the 14-day window that we recommend you keep people in. And that's because, like I'm saying, you could test negative on day 1 and be COVID positive on day 5. And I know that there are providers out there who have had that experience. And so I hope that's clear for people. And I think it's a really important distinction, because we don't want to use those testing resources unnecessarily if they're not going to change our practice. Thanks.
Thank you, Dr. Stone. The next question is for Dr. Jacobs-Lifka. Would cloth masks be appropriate for residents?
Yes, I'm actually really glad that this question was asked, because cloth masks definitely can be appropriate for residents, and they're recommended. So the caveat is if they're able to tolerate wearing them, and you don't want to be putting a mask, even a cloth face covering, on someone who isn't able to remove that mask themselves if they need to, or is incapacitated or having a hard time breathing. Those are definitely situations where Even a cloth face covering would not be appropriate. But if a resident is able to tolerate wearing them, then we would definitely encourage them to wear them, especially when they're outside of their room or if they have to leave the building for any reason. The idea behind universal source control and the reason we recommend cloth face coverings or face masks for everyone, all staff when they're in the building is to prevent sharing your own germs with other people, and potentially provide some protection from sort of larger droplets that may land directly on your mouth and nose. So that is definitely something that we encourage for residents who are able to tolerate wearing them. Thank you.
Thanks so much, Kara. The next one is for Namali, and that is, can nursing homes use the test-based strategy, 2 negative tests 24 hours apart, to move newly admitted residents out of precautions sooner than 14 days?
Thanks, Lisa. Yeah, so I think I covered it, but just to be double certain, the test-based strategy can't be used to give us reassurance that somebody is not incubating COVID in that 14-day quarantine window. So I would not recommend doing a lot of testing of those new admissions or trying to, quote, clear them of COVID by doing, serial, testing to get 2 consecutive negative tests. That strategy isn't appropriate for quarantine. Thanks.
Thanks, Dr. Stone. And to Kara, Dr. Jacob Slifka, there was a follow-up question related to cloth masks and asking how often should they be changed or laundered.
Thank you. That's definitely a good question, because I think that we may have some guidance that's available for the community, although I don't know that we've specifically addressed this in any of our guidance specific for long-term care settings. And so what I will say though is that it is important that they are regularly laundered. So, with the resident, with their regular laundry, that they are regularly laundered, and that you're making sure, because we still, even just like PPE or like face shield, like a face mask, you want to treat that outer portion of the mask or the cloth face covering like it's potentially contaminated. And so that would be the same thing for a resident who's wearing a cloth face covering. You want to treat that outer part like it's potentially contaminated. So you want to make sure that if they or staff are helping them to remove this, put it on, take it off, that you're performing hand hygiene. And I would say regularly, probably, I'm not, what would be ideal is if they had multiple versions of that mask so that you could more easily launder that and use a different mask. I'm going to say, although I'm going to say you could go with something like each day, but that we may not have, CDC may not specifically have recommendations like that, and I can definitely double check and see if anything has been said for these cloth face coverings in general, but I would say that something along those lines would be appropriate. You just want to make sure that you're not using the same one over and over again, and that there's problems with it being turned, not inside out, but having the outer portion facing in, or that you are doing a lot of touching of that, even that cloth face covering without performing hand hygiene. Thank you for that.
Thanks, Carol. And the next question is going to be for Christine, and that is, do you find that nursing home residents are receptive to telehealth, or are they, does that not work as well for them? We'd love any opinions on that.
Thank you. That's an excellent question. I have heard from my colleagues that it is well received, but since we have Dr. Mahajan on the phone who actually provides telehealth, I'm going to turn it over to him. Thank you.
Oh, thanks, Justine, again. And yes, it's a very, very good question, and there's no simple way to answer that. The residents are very receptive to it, but the devil is in the details. Is truly how conducive the visit itself is, and it's just not about the screen size. It's not about being there. There's so many factors that make a telehealth visit an equivalent to a real in-person visit. And those are a few things because, the lag that goes with it because of the bandwidth issues and a lot of times the visits are still done with some really small screens that most of our seniors in the facility are not able to either comprehend or see properly. So paying attention to that, number one. Number two is making sure people at both ends that are helping with the technology as well as the visit are well prepared, and the resident gets what they need out of actual practitioner visit. If it's just checking a box, yes, you made a contact and you can submit a bill, but it's more to that. And so if both the facilities as well as the practitioners realize why we're doing this because of we have the well-being of the resident at heart of this. It's yes, it's about the facility. Yes, it's about the practitioner, but truly, 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 it's about the resident. So if we can make that visit, including all essential elements that go into making a successful telehealth visit, more about the resident than about the facility or practitioner, and that will make this thing even better. And I have seen both. I have seen residents actually just loving it because it's so much easier. But then when those issues around the actual quality of the visit, as in technology quality, as well as the people who are at the facility and at the other end, the practitioner side, are not in it, but for the residents, then it can be problematic. But overall, it has had positive reviews from our residents. Thank you.
Thank you so much. The next question is for Dr. Jacob Pliska. If someone is on isolation after admission from the hospital for 14 days and we are monitoring for COVID symptoms, are N95 masks required or is a surgical mask sufficient?
Thanks for that question. So our guidance in terms of what PPE is recommended for anyone who is suspected or confirmed to have COVID-19 is to wear gloves, gown, eye protection, and an N95 respirator or face mask if a respirator is not available. And so you should be approaching these individuals in that that observation or isolation area after they are admitted with using that same PPE. You should be approaching them like you would be approaching someone who's suspected or confirmed to have COVID-19, because you are essentially treating them like they could have been exposed and could be developing an infection or have developed an infection and may not yet be showing or may not show symptoms. And so we would recommend that you follow that same guidance. So, and that still is regarding the respirator, that you would use an N95 or higher level respirator or face mask if respirators are not available. Thank you.
Thanks, Dr. Jacobs-Lifka. The next question is a follow-up one for Jill. We had lots of questions in the Q&A box that I think people wanted a little more information on the filters. Did you catch us up on that?
Yes, Lisa, thank you. The filters that I referenced earlier on in the call are called Hepa Filters, High Efficiency Particulate Air Filters. And those can be used for vacuuming safely. There's thought about that. There's also some controversy about anytime you vacuum, you do stir up more dust into the air potentially. So a best practice I would recommend would be to conduct vacuuming during, of course, less populated times when there aren't as many residents or staff members in the area. But again, those filters are HEPA, High Efficiency Particulate Air. Thank you.
Great, thank you so much. The next question is, again, for the CDC, for Dr. Jacobs-Lifka. Are residents supposed to be placed in isolation for 14 days after they return from the emergency room?
So as of right now, CDC has recommended that depending on the prevalence of COVID in your community, that you place newly admitted or readmitted residents in that 14-day observation or isolation using all recommended COVID PPE, as we were just describing. And so while we haven't made the recommendation across the board that anyone leaving the facility, even going somewhere like the emergency department or dialysis or some other outpatient visit, would automatically go into that 14-day observation, there's definitely a gray area for residents who leave the facility. And it's really hard to estimate their potential risk for exposure while they're gone. It is definitely possible that they're, depending on where they're at, their own risk factors, the COVID activity in your community, there may be some risk there, but it has definitely been challenging to assess and make recommendations across the board about what that level of risk is. And so one of the things that we have seen is that the answer to this can differ depending on where you're at in the country. There are some states who have made specific recommendations about what to do for these individuals, or have recommended things like trying to make an assessment of their risks and use that to guide you in terms of what you would do when that individual comes back. So I explained that all to say that if you are in an area that has a lot of COVID activity, or if you do have concerns for exposure, then I don't think it would be wrong for you to use that information to guide your actions. And of course, if you ever suspect COVID, if you are ever concerned that person is symptomatic or has known exposures, you definitely want to isolate and test that individual. Thanks.
Thanks so much. The next question is for Christine, and this is for nursing homes who do not have telehealth capabilities. Do you have any recommendations on how to set it up and what technology might be best?
Well, thank you so much for that question. It's an excellent question. So when you say that nursing homes do not have the capabilities under the temporary waiver, I just wanted to be clear that you can actually use a smartphone. There is, from the Office of Civil Rights right now, again under the temporary waiver, you can use an interactive audio and or video communication system like FaceTime or Skype, and that will permit real-time communication between the provider's office and the nursing home resident. You may be in a home that perhaps doesn't have great bandwidth or service in the home. If that is the case, then I would think that it's a good time to turn it over to Dr. Mahajan. So thank you for that.
No worries. It's a pleasure. Always. Thanks, Christine. So Yeah, I mean, I think the question can probably use a little more explanation, because we can talk all day about how to set up a good program. So if the availability to telehealth is because of internet issues and lack of EHR, because I think 10+% of facilities still don't have EHRs, then it's currently it is just a phone call with the stipulations around audio-only telehealth visits still apply, and the future of audio-only once the emergency waiver is over is yet to be known. There are the draft rules are out, and comments I know are another month or so, or maybe 3 weeks. The folks are going to comment on whether the audio only should be kept post-emergency. So that's a much a policy and in a higher level discussion where I'm sure CMS folks can weigh in, but that would come out sometime, end of the year when the rule is finalized. But to me, if we are not talking about audio only, there are 5 key elements of a successful telehealth program. And so the way I call it is it's the people, the places, the technology, requirements, which is regulations too, and the workflow. If you address those 5 things, you will know what's work for that. And if I may take another minute on expansion. So people is really the patient and the family, or the resident and the family, the practitioner, and also people from the facilities, so nursing staff or whoever else is going to be working around it. The places are not only, so you have to know where you're providing services, which is the nursing home itself, but then also where the practitioner is. It's also very important that place is also, you're not calling from a rowdy room where, it's not conducive to a very good quality conversation. And technology involves the software, the hardware, which you already commented on, but also the internet connection and the bandwidth. Regulations will be your federal, your state, and your local health department related regulations that could be around provision of services like such. And then most important thing to me is defining your workflow, where you have the pre-visit, which is the most important, the preparation for the visit, including all the information that you need, medication list, orders, things you're addressing, labs, that you have it available. So when you have that chance, so it's a pre-visit, the actual visit, and post-visit, which is the documentation billing. We definitely have to address all of those. And when you have that in place, that is when you have a successful program. And I'm happy to share that through the QIO or CMS on those, the PPP, TW, as I call them, the 4 key elements.
And thank you, Dr. Mahajan. And I wanted to add, to refer you to the pre-recorded training, because there are qualifiers to what the Office for Civil Rights is, how they're exercising enforcement discretion at this time with the smartphone. So it's important to know what those qualifiers are. Thank you.
Absolutely.
Okay, so I think we're going to get in one more question for CDC. Can some guidance be posted on CDC about residents who leave for ER visits and appointments that allows the ability for the facility team to decide?
Hey, this is Kara, and I wonder if this question is getting at asking whether there's guidance that could specifically say that the facility needs to make a decision, and I think needs to make a decision about this versus guidance specifically on those appointments. I will say that this is an area where we have continued to think about and try to learn more, both in gathering data from facilities, trying to understand what really is the risk of these individuals who are leaving we're not just looking at the ER, but looking at individuals leaving for dialysis or who need to leave either infrequently or frequently for different kinds of medical visits that are off-site. And so this is definitely something that we are looking at. We are looking at outbreaks, we're looking at data we have, and just even trying to assess what the risk level is, how it might differ across the country, and what we may be able to do to try to help minimize the risk of then having transmission if these individuals become infected. So I will say that we are continually looking at this as well as our guidance to see if there is room for us to continue to provide more information to you all. So thank you, I appreciate that.
Thank you, Kara. Next slide, please. Please join us for our next live Q&A session, which will be held on September 24th, again from 4 to 5 p.m. Eastern Time. Registration is required, and we'll chat in the registration link for your reference so you can register that if you have not registered for the series. Next slide, please. Thank you again for your participation in today's call. We hope you found some value in the topics discussed. Please take a moment to complete the survey from today's event. We do use this information that you share with us to improve future sessions. So that will also be in the chat box, and at the conclusion of this call, it will automatically pop up for your convenience. Thank you again, and have a wonderful day.